Hello and good morning, all. My name is Bashar. I'm a member of UOSSM International, a medical doctor and a member of the organizing committee of this conference. I would like to start our conference with a huge welcome and thank you for being with us today in our second Syria Health Research Conference. I also would like to thank all the individuals and organizations who supported our organizing committee in making this conference happen. Again, despite all the difficulties and hardships each and every one of us has been facing in these hard and strange days. We insisted on organizing our conference as it was planned before the outbreak of coronavirus, because now and more than ever, we understand, touch, and believe in the importance of research in our day-to-day life. We can't stop thinking about what could have been done to avoid, prevent, or to stop this virus. But we know for sure that you, as health researchers, your papers, methods, results, conclusions will definitely be the keys to win this war and move forward. Before we begin our conference, there are just a few housekeeping points. When joining the internet link, you will have been given the option of joining through your computer's audio or dialing via telephone. If you have difficulty connecting to the audio, please message the R4HC Amina, which is the host of this event, using the chat box. On a PC or laptop, the chat box is to the right-hand side. If using a phone or tablet, you will have to toggle view to see. Today's webinar is planned to last until 3 p.m. London time. The plenary sessions are one-way audio. So if you would like to ask a question, please use the Q&A box. If you are using a PC or laptop, the Q&A button is in the bottom of the Zoom screen. If you are using a smartphone or tablet, you may have to toggle this. Please have a quick look now. Okay. This webinar is recorded and it will be available on YouTube and Facebook afterwards. Now, you will see the program on the screen. It can also be downloaded on R4HC website homepage. Now, please allow me to welcome our first speaker for today. He is Dr. Maher Al-Aref. Dr. Maher is a Senior Partnership Manager at UOSSM International with a degree in Pharmaceutical Studies and a Master's degree in Health Economics and Politics awarded from Liverpool University in 2011. He has 8 years of experience in the health and humanitarian context in Syria. Please, Dr. Maher, join us.
Thank you for the nice introduction, dear Bashar. Dear members of King's College and Research for Health and Conflict Program, dear members of Syria Public Health Networks, and Syria Research Group, dear colleagues And even more, I am very proud that it formally has the name Syria in it. For a bank transfer request would cause us a huge trouble. And yet, the visibility and attention to the worst conflict and humanitarian crisis in the recent history that has been ongoing for 10 years now. Today, with the COVID-19 pandemic from Idlib city, from a press conference on the response to the humanitarian organization chaired by Idlib Health Directorates, and also covered a lot of the content that I would like to share with you today. So again, I would like to thank you all for creating this space and joining us today. On behalf of my organization, UOSSM, which has been active in this context for more than 8 years, but also specifically for all humanitarian partners and supporters, some of whom may be with us today, but many as well who might not have the chance to make their own voices heard. As shown in the WHO dashboard for Northwest Syria and addressed by the press conference yesterday, by today, there are 4,738 confirmed COVID-19 cases since the detection of the first positive case on the 9th of July. About half of those cases are still active, while 42 people were confirmed dead due to this virus so far. We are beyond the benchmark of 200 cases per day across Northwest as an indicator for community spreading. 19% of the cases are for health workers. Recently and alarmingly also, the first cases in IDP camps were detected. There are so far 215 confirmed cases in camps, which has a high potential to be spreading faster, especially during the nearing winter season. As you might all know, the global strategy to respond to the pandemic is based on the principle of testing, contact, tracing, and isolation. Unfortunately, this approach does not work in conflict settings. It certainly does not work for Northwest Syria, nor for any other parts of the country, where we ask people to stay at home when they have no home, and we ask people to wear masks where there is no masks, and we ask people to wash their hands where there is no water. What we need are solutions that work for us, Syrians. We believe that there is no one-fit-size-for-all approach, but we certainly depend on these solutions. UOSSM is dedicated to support health and well-being individuals for communities affected by the crisis, having, like I mentioned earlier, started more than 8 years ago, providing primary health care programs, secondary and tertiary health care, community health and nutrition, MHPSS, protection services, with more than 1,500 employees as of today. Furthermore, we are very much aware about the importance of evidence-based programming and research, and the nexus between the research and the work of NGOs, which has also been highlighted in the first conference of this kind last year. From the beginning of our intervention in Syria, we have been dealing with lots of numbers and data, including about the pandemic, as we are exposed with the pandemic daily. We have also participated and supported various research projects and papers and benefited. All of the papers and studies were shared with us in return. One of these papers related to COVID-19 situation in Syria will be also presented today. Also, UOSSM is proud to be involved in a research-based partnership recently with King's College on this exact context, funded by NIHR here in the UK. Thank you very much, and please enjoy the conference.
Thank you very much, Dr. Maher Al-Aref. Please allow me to welcome our first keynote speaker for today, Dr. Natasha Howard. Dr. Natasha is an interdisciplinary health policy and system researcher, focused primarily on low and middle income countries. Dr. Howard is also the director of Syria Research Group, which is a team of primarily Syrian health system researchers based at the London School of Hygiene and Tropical Medicine. Dr. Howard, please join us.
Hello, thank you. Good morning or afternoon, everybody, or if you're in my side of the world, good evening. And I wanted to start by thanking the conference organizers for inviting me. Just a slight correction, I'm not the director of SURGE, but we'll get to that as we go forward. I just wanted to note that I saw that you invited two white British academics as keynote speakers, which I thought was quite a bold move given the dearth of British academics living in Syria and current global initiatives for decolonization and intersectionality. Hopefully next year you won't choose two of us, but you did include a woman, so marks for gender balancing. However, despite that, the program looks really good and I think it will be a wonderful day. For those of you who don't know me, which to be fair is probably most of you because I aim to keep a low profile, I am an associate professor at the National University of Singapore, Saw Swee Hock School of Public Health, and also at London School of Hygiene and Tropical Medicine in the UK. I've been based in Singapore since February, so our experience of COVID-19 pandemic and responses are, I would guess, considerably different from what most of you have had to deal with. So today, in the few minutes I have, I want to talk about specifically health research needs and approaches for Syria and in Syria, and a little bit about SURGE, Syria Research Group, which is a new research group that I'm part of, and what we're trying to do as we first find our way. I'll keep my remarks brief because I only have a few minutes now, but if you do have any questions about the work of SURGE or the group, you can find Yazan Dwedari or Mervat Al-Hafer, who are both attending today from our team, and ask them all the questions you want. So we've all heard that the Syrian conflict is one of the most extensively studied and documented contemporary conflicts. Whether that is good or bad, that's the status as we know it. However, despite this, a recent review by Jabor and colleagues found that much of that health literature related to Syria since 2011 is actually about refugees, with relatively few studies focused on the health of populations within Syria, and even fewer contextualizing health issues in relation to the conflict or describing something beyond or moving beyond health problems, health needs. This is understandable given the complexities of conducting research effectively in a conflict-affected country and the issues within Syria specifically. However, it's a gap that we as researchers and practitioners do need to try and find a way to address. So many of you here today are working to address these gaps in Syria's health research literature. And some of that work will be presented today, which is fantastic. And a lot of it looks really, really great. So coming back in my comments to what is Surge and why should anybody create another research group for Syria. So as Dr. Maher mentioned, it's a group of predominantly early career Syrian researchers, and it's co-hosted between two global academic institutions, namely NUS School of Public Health in Singapore and London School of Hygiene Tropical Medicine in the UK. So the question why? We've been conducting work in Syria for a few years now. And Yazan, Mervet, and I noted there's a clear need for research that's a bit more participatory, a bit more grounded with local realities. And particularly, the emphasis is on qualitative research with participants rather than on participants in Syria and in the global diaspora. So that's one of the things that's a little bit different about what we're trying to do. Surge is small. We're still quite flexible and well networked. It's a group of academics and volunteers. Most importantly, we're not trying to be like every other academic group. So watch this space, we'll see what happens. Hard to predict at this stage. But our approach is Syrian majority, Syrian led, using co-design and participatory methods, and focusing on primarily exploratory topics, because we know there are already many researchers who are working on more established research topics, and that's not where we feel that we could add most value. So for example, in addition to ongoing participatory qualitative research on health system governance and adaptation across Syria, we're also looking at COVID-19 response governance and community level prevention initiatives. And this comes back to what Dr. Maher mentioned, that we need to propose relevant solutions based on realities rather than on what we as academics globally think works in terms of a response. So this is particularly true in displaced communities. And we've done an initial round of questionnaires and survey work in IDP camps that we are analyzing now in order to try and address this issue of the fact that the standard public health response just doesn't work particularly effectively. Additionally, we're looking at some of the gender issues that have been arising because of the conflict. So women's lived experiences as healthcare providers and also service users. This is, so far it has been in opposition controlled areas, though we may do it more broadly if possible. And also looking a bit at women's experiences of discrimination, gender-based violence, etc. during COVID-19, whether that has had an impact. So without taking much more time, we're still experimenting, both with methods, with approaches, with ways that we can support contributors who are within Syria. And so if anybody has any ideas today, please do share them with Yazan and Mervat, because by then I will probably not be able to be here any longer because of the time difference. So I want to end my remarks with a call to all of us, whether as academics, practitioners, advocates, or some combination of that we all find ways to support and promote the research efforts of those who are still inside Syria or who are new to the diaspora. Because some people are already well established, but there are still many, many highly capable researchers or people who would be interested in research who don't yet have that chance. And so we need to find ways to provide more opportunities. Obviously, we all need to advance our own careers, but we can always do that by finding ways and means to do this in collaboration and by supporting those whose lives have been so affected and disrupted by this protracted conflict. I would like to end here and say thank you again to the organizers. And I hope you all enjoy today's conference and learn a lot, network a lot, and from that we can take forward new initiatives. So thank you all again.
Thank you very much, Dr. Howard, for your presentation and for your comments, which will definitely be considered as we develop our conference. Now, we are moving to our first plenary session, which addresses the impact of COVID-19 on health in Syria. This session will have 3 presentations, and we would like to start with modeling the impact of different interventions on the COVID-19 outbreak in northwest Syria. This presentation will be by Manar Marzouk and Dr. Naser Almhawish. Manar is a global health researcher with a focus on health policy and health systems in refugee and conflict settings. She is currently working with COVID-19 International Modeling Consortium at the University of Oxford. And Dr. Naser Almhawish is a medical doctor with extensive experience in surveillance systems. Currently, he is surveillance coordinator at Early Warning Alert and Response Network at the in the northwest of Syria. Please, Manar and Naser, join us.
Hi, thank you very much, Bashar, for the introduction. Let me share my screen, just a second. Can you see my screen? No?
Yes,
can you see?
Yeah.
Sorry? Yeah.
Yes,
so yeah, thank you very much for the opportunity to participate in the conference. And here we are presenting our work, like from COVID-19 modeling group. So we established a group. So I'm a member of the COMO consortium, and also like with team leader for the COMO modeling group in the northwest of Syria. So here we're presenting the work from also the participation of all our colleagues. Their names are here and they couldn't participate with us. So I think maybe we can start with Dr. Naser. He will be starting with the background, and then I'll follow up with the results.
Thank you, Manar, and thank you, Bashar, and all the organizers for allowing us the opportunity to show some of the findings that we got in our modeling. So the focus of this model was on Northwest Syria specifically, not the whole country, as this is an area with more information that we get. It includes parts of majority of Idlib and the northern parts of Aleppo Governorate, and multiple controlling forces. It's a little bit of a complicated situation there. But this area hosts almost 4.2 million people, more than half of them are IDPs, and almost a quarter of those population are resident in camps. When we look at this area, we can see that the attacks on healthcare, the destruction of the infrastructure, whether it's related to health or wash or transportation, it all affected the possibilities to provide proper services in this area. In addition to the scarcity of the healthcare workers with much below than what's required in the sphere standards. The population pyramid there is skewed a little bit to younger ages, which may be a good thing when we talk about COVID in particular, with less people with older ages. but with the weak health system, with poor wash status, with the overcrowdedness in that area, all those gives extra burden on the system and more difficulty to implement proper mitigation measures in that area. When we talk about the COVID situation in general, it was introduced later on in this area when we compare it to other regions of Syria, Northeast or the government-held areas, but it happened there, unfortunately. It happened at the beginning of July, and the worst case scenario took place with one of the healthcare providers being the index case at that point of time since 9th of July. As of the 28th of October, we have 4,700 cases and more. And as of yesterday, we exceeded the number of 5,000, unfortunately, with more than 40 attributed deaths to this. We noted also that as of mid-September, end of September, the peak started to increase. Everyone thought that this is the peak, but no, it's not true. It's the beginning of it, unfortunately. And community transmission is getting bigger and bigger with positivity rate with more than 30%. And when we look at some community level, we can find it at more than 50%, unfortunately. And when it comes to what's prepared for hospital beds, we have nearly 200 beds available with the ICU, 112 so far, including 83 ventilators. And with the approach of having some community-based isolation centers and some dedicated hospitals, but still the numbers are very low, unfortunately. Some mitigation measures were conducted at the beginning when people were afraid of the introduction of the virus, some partial lockdowns in some area, school closure till the end of September, and increasing and sensitizing the population about personal hygiene, hand washing, and some minimal travel restrictions, including the closure of the Syrian-Turkish borders, of course. For the model, it's based on an age-structured SEIR modeling for it, and with the development of this model by the COMO consortium from the University of Oxford and Cornell. And it's not just implemented, of course, in Syria. We are talking about more than 45 sites globally involved in this, with interaction between the developers, the country level expert committees, and policy makers to reach the proper policy briefing to aid the policy makers in that. This is a participatory approach. It's not just people sitting in their offices and just talking about it. On our level in Northwest Syria, a group of experts, members from the task force, the national and international involved in it, some policymakers provided their feedback and their ideas about how to modify the interventions in that, in addition to, of course, the consultation of the COMO consortium themselves. I'll see here that when we come to the data, we use the epidemiological data from ACU EWARN, the Health Information System Unit for Northwest Syria for the population and for the health capacity, in addition to some screening conducted by one of the partners, UDA. Now I'll move to Manar so she can continue with the scenarios.
Thank you, Naser. So in this model, we have simulated 4 scenarios for COVID-19 interventions in the Northwest. So the first scenario is the baseline current situation. We're modeling the current coverage of 4 interventions: international travel ban, hand washing, mask wearing, and school closures. With the second scenario, we introduced, we were modeling the impact of school opening on 15th of September, and we introduced three interventions for for a shorter period for 8 weeks. Whereas with the third scenario, we introduced additional 2 interventions: self-isolation if symptomatic, and social distancing compared to the baseline, and we increased the coverage of and interventions such as hand washing and face masks. And the fourth scenario, we introduced high coverage of interventions, similar to the scenario 3, but only we increased the coverage of interventions, especially in particular for hand washing and face masks interventions that we thought it will be feasible in the context of the Northwest. So we'll start introducing the findings one by one. So first, for the first scenario, we projected the impact, as said, the current mitigation measures, combination of interventions, for interventions, international travel ban, face mask, hand washing, and school closure. So in this, we are the model predict that around 59% of the population will be infected, and the peak will be reached around mid-November. And it's predicting that the death will be, the total COVID-19 attributable death will be around cumulative 2,000 by the end of the year. But as you see, the curve is continuing till the, so yeah, till the after 2020. And then with the second scenario, we projected the impact of school opening in combination of another 3 low coverage intervention, face masks, hand washing, and international travel ban, implemented for 8 weeks only. And the model show that this scenario will result in slight increase in the infection of population because it has been introduced for shorter period. And also with the COVID-19 attributable death, the cumulative death will be slightly higher than the first scenario, the current scenario. And so the death will be increased by 7.6%. And then with the third scenario, we have projected the impact of combination of 6 moderate coverage interventions. Here we added self-isolation if symptomatic and social physical distancing. We prefer now to call it physical distancing, it's better. And we implemented these measures until the end of 2020. And the model predicts that around this scenario will result in a decrease in the infection percentage of population infected into 34%. And as well, the death will be is expected to be reduced and 67% compared to the current situation, the baseline. Whereas with the fourth scenario, here we projected the impact of combination of 6 high coverage interventions, the same as the scenario 3, but the increased the level of coverage and introduced until end of 2020. So in this scenario, it's projecting that there will be a massive decrease in the percentage of population infected. Nevertheless, it's worth mentioning that the curve is continuing till next year, so we don't know what will be happening after 2020. And then also it predicts that the death will be decreased by 93%. So this is summary for key findings. I'll give a couple of seconds for you to see the comparison. So the here we compared between the epi curve for each of the scenarios, and if you see that the I mean, with the second scenario, it's not predicting to make massive change into the current situation, whereas with the third and fourth, the peak of the epidemic is predicted to be shifted until next year. And although we don't know what will happen after 2020, because our simulation period was only for until 2020, now in the next versions we're modeling for next year. But I think we think it's positive because it allows time for policymakers if they to set the measures, to put and introduce measures, and also like it allows in case there will be vaccine, hopefully. So so we always shifting the curve, we consider it as positive with the third and fourth scenarios. So in this comparison, we're comparing between the fourth scenario in terms of the death. So in this model, it predicts that the fourth scenario, introducing 6 non-pharmaceutical interventions with high coverage, is the most effective in averting COVID-19 attributable death. Nevertheless, I think it's important to consider the context when we are interpreting these findings, because I mean, introducing high level of coverage of non-pharmaceutical interventions may have other unintended negative consequences on the economy, on mental health. Also, I mean, when we think also of school closure, I mean, it's important to think of the development of children and how it will be impacted in situation conflict where they missed already over 3 years of education. Regarding hospital occupancy, it's predicted that scenario 3 and 4, mid and high coverage, would decrease the pressure on health system and hospital occupancy, in particular the number of beds, hospital beds required. As you see in the fourth scenario, the number of hospital beds is almost like 8 times less than the current situation. Nevertheless, even with these like very strict measures, the fourth scenario, we still I mean, the health system would be overwhelmed by COVID-19 outbreak, because we're talking about the maximum available hospital beds at the moment allocated for COVID-19 is 200. And in addition, the model, it doesn't take into account non-COVID-19 patients who will be requiring hospitals, and they may be like increase of death of COVID-19 related, not attributable deaths. So regarding the assumptions, so the model data, the main cases and death data, we have got them from EWAR, and it's based on data from the 28th of August. And the hospitalization rate, infection hospitalization rate, we have increased it a bit. We doubled it to reflect on the vulnerability among the Northwest population. And the infection, probability of infection, we have set it as 0.02. Nevertheless, this now we are able to calculate it because there are more cases, so it will be calculated in the next versions of the study. And the health system capacity at the time where we did the simulation, we set it at the number of hospital beds, ICU beds, and ventilators allocated for COVID-19 patients were 75, 40, and 36 respectively. So Naser?
Yeah, so we knew from the start that this is not the perfect, of course, nothing is perfect anyway. So looking at the challenges that we faced and the limitations that we acknowledged for the modeling, we knew that the edge structure model will not consider some of the other factors. Like we have high population density in Northwest Syria, especially in the camp area with more than 5,000 persons per square kilometer. Some socioeconomic factors also. We are talking about a new disease that it's less than 1 year old, if we may say this, and people are still learning more and more about the infectivity of it, the manifestation, and all this would be more clear in time, hopefully. One of the difficulties that we faced is related to the mortality data and not having proper registration, not having proper mortality surveys or mortality surveillance per se to have more accurate data in this, especially that we are in a conflict zone. One airstrike can lead to high number of deaths. Is it related? Not related? This is clearly not the situation with this. Another problem is related to the governance and the fragmentation of the policymakers in the field. As we showed in the map for controlling forces, we have multiple actors in the field, and it's not easy to have one unified decision when it comes to some interventions. Some of the non-pharmaceutical interventions are a little bit difficult to implement because of some of the above mentioned reasons, some of the lockdowns, the shielding of the elderly, and the consequences that it may have on the psychological aspect for it when it comes to the social network in the field also. We're looking at the options of having some community screenings aside from the contact tracing, the regular phases that are conducted in the field, which is again not an easy thing to conduct at the moment. And this links to the possibility of having some surveys and some RDT utilization or the serology with ELISA to see if there is a need to support some self-isolation practices and to have proper assessment of the spread of the virus. So in brief, when we just go fast on the conclusion from what we got, that the higher the non-pharmaceutical intervention, as expected, will have a better effect to decrease the burden on the health system. In scenario one, we see this is the situation in the field, the result of almost 60% of the population to be infected, which is a high number, and the health system will not be able to tolerate it, with more than 2,000 attributed deaths. Introducing mitigation measures for a short period of time in scenario 2 for 8 weeks will not have bigger difference. Whereas when we have a combination of non-pharmaceutical intervention like the excess of hand washing, the physical and social distancing, the proper implementation of face mask, and so on, will till the end of 2020 in both scenario 3 and 4, this will help in decreasing the bed occupancy rates at the hospitals, which will ease the burden on the health facilities and avert some of the attributed deaths by 70% and more than 90% based on the scenario. Also, we need to mention that although school closure is predicted to have good consequences of it, but as Manar mentioned, it's not an easy decision to make. We have the future of the children. We need to know how to be able to cope with this situation. Will their staying at home be the solution of that? Won't they go to the community? And all the implications for that. Some of the non-pharmaceutical intervention, just like shielding and some self-isolation and quarantine, should be addressed carefully after assessing the psychosocial networks and the field situation. We are in a conflict zone, and the connection and the networks between the people may get bigger, and it's not easy to implement this kind of interventions. So far, the most feasible interventions would be the face mask wearing and the hand washing. It's more easy and feasible to do, although we know the difficulties, the availability of water and the hygiene kits and the availability of the masks themselves, although they may decrease the number of deaths by more than 90%. And finally, we need to see that some additional public health and social protection should be used, and we need to discuss this with the policymakers to have proper implementation of the non-pharmaceutical intervention. Now back to Manar for final remarks.
Thank you very much, Naser. So I think in our work, we want to acknowledge all people who helped us, in particular, Professor Lisa White, and also I want to mention Professor Natasha Howard, and all people who participated, and Dr. Munzer Khalil, and these names. So I think the questions we will get them probably after the. So we look forward to any questions you have, and thank you very much.
Yeah, thank you very much, Manar and Naser. I'd like to remind our participants that if you have questions, you can use the Q&A box. If you're using a PC or laptop, the Q&A button is in the bottom of the Zoom screen. If you're using a smartphone or tablet, you may have to toggle this. And please, when you ask a question, try to mention the presentation that you're asking about, or the presenter that you would like to answer your question. Now we're moving to our next presentation in our first theme, which is the impact of COVID-19 on health in Syria. And our next presenter is Abdulkarim Ekzayez, and his presentation is on COVID-19 response in northwest Syria. Dr. Abdulkarim is a Syrian medical doctor and an epidemiologist. He is currently a research associate and a PhD student at King's College London. He is also involved in several other projects and research with the academic and policy institutes, including the AU Chatham House and others. And he is also a founding member of the organizing committee of this health research conference. Please, Abdulkarim, join us.
Thank you very much, Bashar, for chairing this conference, and thank you for all our panelists and attendees for their interest in this conference. So my presentation will be brief after we heard from Manar and Naser about the different non-pharmaceutical interventions, effectiveness in northwest of Syria. My presentation really looks at the general governance, health governance issues during COVID-19 outbreak in Syria, and also community engagement, which is, I think, key. So as you know, in Syria currently, we have more than 15,000 confirmed cases across the different areas of control in Syria. In the government-controlled areas, we have around 6,000 confirmed cases with around 300 deaths. In northeast of Syria, we have around 4,000 cases with about 120 deaths. And in northwest, we have around 5,000 cases with 40 deaths. But as we all know, these numbers could be only a fraction of the real numbers, because the testing capacities across the country is very limited. So as you know, they are in any response to outbreak, usually you need to have a national plan for response. And in the case of Syria, this was not possible because of the division that the country is experiencing because of the conflict. So then the governmental areas, the Ministry of Health is the lead for the COVID-19 related planning. In the northeast, you have the health department, self-administration, and in the northwest, the health governance actually is very challenging, because you do not have one like military or political governing body for the whole region, and you do not have one local health authority. So the governance issue has been problematic. And that's why in this paper that we published in the Journal of Public Health, we looked at the different governance techniques that has been used in northwest of Syria, and also the community engagement strategies that try to fill in gaps in the COVID-19 response. So the idea behind this paper was a collaborative work between King's College London from one side, and also the different health actors involved in the COVID-19 response in northwest of Syria, mainly Idlib Health Directorate, the White Helmets, the Syria Civil Defense, the E1, which Naser presented about earlier,
It's off, I think, but let me double check. Let me.
Yeah, and also in North Syria, the health has experienced a lot of challenges. And these.
Sorry to interrupt, I think your voice went off for like a minute. If you just go back.
Okay. Sure. So the health system in North Syria experienced a lot of challenges related to, for example, attacks on healthcare and the lack of health infrastructure and lack of one central health governance system. But also, in addition to these challenges, there have been specific challenges related to COVID-19, which put this area in particular at a higher risk. These challenges are related first to displacement. We have only in between December 2019 and April 2020, as per the UN OCHA, we have more than 1.2 million people who have been displaced in this region. And more than 68 health facilities in the same period have been attacked. Also, to make the response even more challenging, the UN Security Council resolution about cross-border humanitarian response 2165 in 2014, this resolution has expired. And as you know, the Russians and China they have vetoed the extension of this resolution, which made the humanitarian response in Northwest Syria even more challenging. Also, the capacity of the health system there was very limited. We heard some numbers from Naser, so I'm not going to repeat these numbers, but I would like to focus on the key features of the COVID-19 response in Northwest of Syria. So the first thing to bear in mind that in any outbreak or pandemic response, you need to have a national level plan with clear strategies of what we really need from each measure that we are introducing. For example, if we're implementing a lockdown, then we need to know that the goal of this lockdown is, for example, to delay the outbreak by X amount of months or by X amount of weeks. And this was very challenging to have in Northwest of Syria. Apparently, the WHO and the health cluster in Gaziantep, they started to establish a kind of a governing body or a technical group, which is called the COVID-19 Task Force in Gaziantep. But the point is that WHO, because they do not have physical presence in these areas of the country, they really cannot engage in really field level activities related to the response. They were active with the task force in developing the guidelines, but there was a need to have a different governance system. And this was when the Idlib Health Directorate came with the civil defense, the white helmet, and they established a governing body to manage the response with a clear plan that we need to stop the virus from being imported into these areas, with a plan that they will delay this for at least 3 to 6 months until they have some time to scale up the health system capacity. And indeed, this what happened, because the first confirmed case of COVID-19 in the governmental health areas in Syria was announced, I think, in April, while the first case of confirmed case in northwest of Syria was not identified until July, late July. So they were able really to delay the onset of the outbreak in northwest of Syria for at least 3 or even more, 3 or more months. What's the strategies in terms of leadership? So instead of having one top-down system, there was kind of a bottom-up approach where you have the different NGOs coming together under a leadership from the Idlib Health Directorate as a technical body, not as an authority. And then you have the white helmets as the one involved in the rescue and in the community-based interventions. And under this, they called for a massive social mobilization activities. And they called for a campaign for volunteers, which is called the campaign called Volunteers Against Corona. And this campaign now have thousands of volunteers covering all different neighborhoods in the region. So now in each neighborhood, you would have a committee of volunteers with clear tasks and responsibilities of what they need to do. And those committees in neighborhoods level, they are connected to a central coordination mechanism of these volunteers against Corona campaign. So I think this was I would say innovative in a way that they found solutions on how to really replace a top-down governance system. I can see here a question in the chat. There's no slides for this presentation, so it's only oral presentation. There are no slides. I can share the link for the paper later. So this is about the feature of the governance system, and then and community engagement and mobilization. But there was a unique role for Diaspora Networks in supporting these this response. And I think this was the case across the different regions in Syria, because we know that the Syrian diaspora are active in supporting the different health actors inside Syria. So in the case of northwest of Syria, different platforms were used and utilized, including Skype, like WhatsApp, Zoom, Facebook. They established specific groups for first, some groups were specific for research related activities, and some other groups were specific to clinical practices. And some other groups, for example, were related to infection control. And the diaspora, they had a key role in managing knowledge, which is I think is very needed, because on the ground you have people focusing on life-saving activities and on different priorities, while for diaspora they played key role in managing knowledge, especially that we're dealing with a new pathogen. So it's important to have up-to-date information with dedicated people to update the people in the field. This role was played by Diaspora Networks. The third feature was learning from the polio outbreak. The polio outbreak in 2013 was the first outbreak that hit the country. And learning from this outbreak, we learned how to establish, for example, a task force. We learned how to go on the community level to establish volunteers committees who would be able to go door to door. In the polio case, this was to deliver vaccination. Here, this was to deliver messaging and to raise awareness. And also the fourth feature was a proactive risk assessment for the surveillance system. The early warning and response network, E1, that Naser briefed us about, played a key role even before the COVID-19 pandemic. So in 2019, the E1, they were preparing for a flu-like outbreak in these regions. And they were pushing the WHO and other agencies to support them with the required PCR machines and other testing capabilities. And because of these proactive assessments, they were able to detect influenza H1N1 outbreak in November 2019, even before the COVID-19 pandemic. And after that, they were able to scale up the testing capacity gradually as they go. And it's very challenging to scale up the testing capacity, but still this proactive approach, I think this worked properly. And then the non-pharmaceutical interventions, I think these were covered already. And the sixth feature was about how to have a national plan to scale up the health system capacity. Northwest of Syria, this plan was focusing on first patient triage. So most of the health facilities now, they have specific areas for triage to identify suspected COVID-19 cases, and then community-based isolation centers, which I think they are very needed, especially in camp setting and in settings where you have a lot of displaced people. You need to have places where people, they can practice the self-isolation if they have confirmed cases. And lastly, increasing the clinical capacity, the ICU capacity of the systems. And lastly, the last feature was related to utilizing digital solutions. So as early as of March 2020, an organization, it's called Violet Organization, reached out to us in King's College London. We worked with them to develop a self-assessment algorithm for COVID-19 symptoms. And this was ready by April 2020, which is really earlier than even some self-assessment assessment algorithms or websites or services in developed countries. So these services were available to residents of northwest of Syria starting from April 2020, which I think this was innovative. And now there are also all other options to utilize digital solutions to support the surveillance system, but this are yet to be implemented, but are thought of generally. So this is in a brief. I know that my presentation focused on the qualitative element of how to assess the national level COVID-19 response in Syria, focusing on Northwest, and I'm happy to take questions after the third presentation. Thank you very much.
Thank you very much, Abdulkarim. And now we are moving to our third presentation, our first theme. This presentation is by Amina, Olabi, and Houssam. It's on COVID-19 in fragile states, barriers, and facilitators to health promotions. Amina is a member of the UOSSM UK team, focusing on the research aspects of UOSSM's work. She holds a biomedical degree from the University of Liverpool, and she is also a founding member of the annual Syrian Health Research Conference. And with her, we have Houssam Alnahas, who is a physician with over or more than 8 years of experience in the field of humanitarian health and public health, and he is a public health researcher with strong skill sets on information management and focus towards studying health systems in conflicts. He has extensive experience in data collection, data analysis, and program implementation. Please, Amina and Houssam, join us.
Okay, thank you very much, Bashar, for that. And good morning, everyone. Just a quick note, Houssam, my co-presenter, is actually showing the presentation, the slides. So thank you very much once again for this opportunity to talk about our research on COVID-19 in Syria. This research was done in collaboration with LSTM and UOSSM, as well as Houssam from Johns Hopkins. So just to start off, this is a quick outline of what we will be talking about today. So our research took place between July and August for the data collection. And now we will move on to the introduction. So just a bit of a brief overview of the Syrian crisis. I'm sure most of us know this, but it's been classified as the biggest humanitarian and refugee crisis of our time. And the reason for this is very obvious, as you can see on the figures here, with over 500,000 people dying, and these are just the documented deaths. And specifically on the healthcare system, the losses have been really huge, with figures coming out of Idlib in 2019 showing that there were only 600 physicians providing healthcare for over 4 million people living there. So as you can tell from that, and the response in the opposition-held area, specifically northwest Syria, which is where our study took place, heavily relied on local organizations and NGOs to respond to the health needs of the population there.
So as mentioned by Naser and Manar, and also Karim, Northwest Syria had been hit hard by COVID-19 since late July this year. So as of October 28th, there are around 4,700 cases and around 50 deaths. And mainly Idlib is contributing to the highest number in terms of mortality and morbidity. So with the lack of therapeutic and vaccines and rapid tests, the focus is shifted on preventing a large outbreak in northwestern Syria. Prevention campaigns are being carried out in the area. However, it was highlighted by local organizations that an assessment is needed to better understand the factors that may help or hinder people from following the guidelines and recommendations, which are being covered by community engagement activities.
So for the research objectives, we wanted to do three main things. We wanted to describe the current prevention response. we wanted to identify the facilitators and barriers affecting the delivery and uptake of the messages that were being given out. And we wanted to also provide recommendations for actors to better tailor the COVID-19 response in Northwest Syria. We based our study on a widely used model called the health belief model, which includes 6 different constructs for health promotion. And we will get more into those constructs when we get to the results section. So for our methodology, we used a combined approach. So we did a document review to gain insight into the different prevention efforts and the campaigns. And we also did an in-depth qualitative interviews. Of course, we gained ethical approval from the relevant bodies, such as the School of Tropical Medicine in Liverpool, as well as the Idlib Health Directorate. And we considered numerous ethical considerations before conducting any sort of research, because of course, it's taking place in a very fragile setting. Our sampling strategy involved the data was collected by trained data collectors who work inside Syria. So it was done remotely, and their training took place through video conference call. The final sample included 3 camps and 2 urban cities, so 5 sites in total. And we tried to include the perspective of host as well as displaced population. The accessible areas were clustered into clusters of similar features, and then from within those clusters, we chose 5 at random. The final sample consisted 15 participants, 5 of which were key informants and 10 were community members. And we aimed to, from each community, have 1 male, 1 female, and 1 key informant. The reason why we overcompensated on the community members and increased the number compared to key informants is because a lot of the times the key informant positions are male dominated. So we wanted to balance out the gender bias through that. And the sampling strategy was purposive, and it was led by UOSSM on the ground. And we tried to include a variety of experiences such as displacement status and gender, etc. So for the data analysis, we listened to the recordings, and the main researchers were fluent Arabic speakers. So we did the translation and then the transcription. We used thematic analysis for the analysis, and we used the health belief model to guide us through it. We used a 5-step process where we listened to the data and got familiar with it and took notes of any significant themes that were emerging. We then developed a coding framework which was based on the health belief model. We then coded the data where we manually moved the relevant data into specific themes, and we used a software called Quirkos for the visualization of the themes. We then charted the data into the relevant framework, and then the final stage was the mapping and the sort of putting the data into similarities and differences.
In terms of the results for this research, I'll start with a quick introduction about the demographics. So we managed to have a good variation in our samples. So the respondents were 40% females, and the age ranged between 27 to 73 years. From people with no formal education to people who are holding university degrees. 60% of the responders were IDPs, and 40% were among the host populations. The focused area was in Idlib city and its countryside.
So we now move to our results, which are based on the health belief model. So the first construct, which was the perceived susceptibility, is concerned with how at risk a person sees themselves of contracting COVID-19 in our case. And it was very clear that participants really realized the contagious nature and saw themselves at risk. However, one thing that did come out was the fact that participants often place themselves out of specific risk groups. So they would say, a young person would say, it only affects the elderly, and so on. And overall, 70% linked it to internal factors, for example, someone's age, and only 30% linked it to their behavior, for example, social distancing or sort of hygiene practices. And which was true for all of the different constructs was that there was a mysterious nature of the virus that kept on coming up, as seen on this quote here. For the perceived severity, which is concerned with how serious a person thinks the health condition is. It was very clear that once again, the participants saw themselves as that the risk was severe, and that if the consequences of contracting the virus were very severe. However, they did say that not everybody in their community views it the same way, and some people think that it's just down to a political hype or different theories they might have on why it's being portrayed in that way. Importantly, all of the participants viewed the severity through a very context-specific angle. So they often referenced their specific living conditions as reasons why the consequences of the outbreak would be so severe. And also the opposite was mentioned. So a lot of people commented saying that COVID or an outbreak of it would not be as severe as what they had already lived through with conflict and war. So they were sort of desensitized to the tragedy or suffering in general. With the benefits of engagement, a lot of people quoted that they would they have fears for their families or people they love of getting the virus, and that was a motivator for them to adhere to prevention guidelines. And this was correlated with people thinking that it was a severe threat. So people who thought that COVID was a severe threat in their area also saw benefit in engaging with prevention efforts. And 13 out of 15 participants mentioned the responsibility to protect others as a sort of humanitarian or religious duty to look after people who are already in a very fragile setting. And people also expressed the fact that so they were just also expressing the fact that they would go to the healthcare center as a legitimate sort of authority, which shows that this is a facilitator to uptake because they see the healthcare system as a legitimate one. With barriers to engagement, I think a lot of this was mentioned before. So overcrowded living, the difficulty to social distance from people and self-isolate if you had symptoms, the unhygienic conditions, people not believing in COVID, people around them, so making it more difficult for them to prevent it. And of course, the lack of necessary materials. Stigma also came up. I think a lot of it was centered around the socioeconomic situation and the fact that they do not have the means to afford protective items. And as well as one interesting perspective that was brought up by an imam who stated that sometimes religious text was being misinterpreted, and people were quoting the fact that the protection of God was more significant than anything that they could do. With the more on the barriers, there was a lack of trust in the capacity of the health system, mainly because they would quote things like the lack of resources that the health system had access to, and as well as the long-term nature of the outbreak. And they would say that we don't see it as being something that we can sustain in terms of the prevention efforts. Poverty was at the center of all of this. Everything that was mentioned was centered around poverty and the socioeconomic situation. And then we move on to the perceived self-efficacy. This was, again, there was a wide variation. There were people that said we had a huge role to play in preventing the outbreak, and others who said it was the sort of authorities' perspective and individuals don't really have an effect over it. But the majority of people did say that they have a responsibility and a humanitarian duty to do their part.
In terms of the cues to actions, people like the people we interviewed mainly relied on media like news and the social media to get the information about the COVID-19, and also relied on the awareness campaigns that were run by NGOs inside the city and in the countrysides. Other sources for information were from people who acquired the disease, and they communicated with people inside the city, or people who were tracking the news around the globe and collecting information about the burden of the disease on different countries. For the discussion, the main two themes that we have out of this study is to characterize the facilitators and barriers to community engagement. So as you notice here in the slide, both the family and the culture play an important role in as facilitators and as barriers as well. So as Amina mentioned, for those who were aware and were worried about their families and their children, they tried to engage into the community activities and the community efforts to battle the disease. But on the other hand, many mentioned that when it comes to their families, and if they got infected, there's no way they can isolate them and stay away from them. So it can play like it can have double role in this regard. For the culture, again, the misinterpretation of the religious text can be a barrier for engagement, but at the same time, because of the culture that is related to reduce the harm to the community and the economy, people were more willing to participate in the efforts. In terms of facilitators, knowledge was characterized as a facilitator, because most of the people we interviewed expressed enough knowledge about the disease, the risk, and the severity. In terms of barriers, the misinformation comes in the first place due to the false news and misinformation and disinformation that is not controlled in the area. Attacks on healthcare, and as Karim mentioned, had a negative impact on the health facilities, the health services, the healthcare providers, and also threatened the access to safe care to people. So people were reluctant to report their disease, so they don't be isolated in health facilities that can be targeted. Implementation gaps, we can see in this graph that risk communication was implemented widely in the whole province, but when it comes to interventions that requires more resources on community level, we noticed that there was a lack in those kind of activities. Also, because of the authority gaps, there was no obligatory measurements that like in terms of like home isolation or lockdown. In terms of the recommendations and research gaps, two main categories we can talk about: the response tailoring and better communication with stakeholders. So in terms of response tailoring, of course, since people were perceiving NGOs and health actors within Idlib as the trusted entities for healthcare providing support, funding, or capacity building to the Syrian NGOs and health actors would enhance the trust in the community. Also integrating the family in prevention messaging and mitigation measures, because as we mentioned, family can be a barrier as a facilitator. So as long as we engage the family and enhance the facilitator part of the family element, this will enhance the community response. Inform intervention with research that study cultural complexities. Of course, this is a recommendation before any intervention in a fragile setting with limited resources. Informed interventions will allow for a better response, better engagement with the community, better communication with stakeholders, not only on community level, but local, national, and international levels, to eliminate misinformation and provide regular updates to all stakeholders. So as a conclusion, our finding shows that the response in the Northwest Syria has gaps, but overall was effective in engaging communities, as demonstrated by reports of high self-efficacy and social responsibility to care for the community. This highlights the importance of evidence-based programming when it comes to working with vulnerable populations, as the needs are likely to be affected by a multitude of factors. Appropriateness of response to the circumstances should be centric to any community engagement effort, and practical solution must be added to health promotion efforts. So lastly, we would like to thank all those who contributed to this paper, and I will leave the final remarks to Amina.
Thank you very much, everyone. I think we're ready for any questions that you may have.
Thank you very much. I believe that we have a question for you from, and I hope I pronounced the name right, from Shevgat Bahar. They are asking how many people did you interview and what was their education category distribution?
Yeah, so we interviewed in total 15 people, and the distribution was quite varied. So we had people with literally no formal education to people with higher university degrees. And we made sure to have that sort of variation because we know from literature that, you know, formal education has a huge effect on health literacy, which correlates to engagement and health promotion. But interestingly, that was on one side of the spectrum, but then on the other side of the spectrum, we saw that even people with high education levels and high health literacy showed sort of skepticism towards COVID-19 prevention, and that may be attributed to many things, including sort of the exposure to more, you know, theories and things that would, or also even fake news and things like that. So yeah, we made sure we felt like the education level was a vital thing to get a wide variation.
Okay, thank you very much. We have another question to Manar and Naser. It's from an anonymous attendee. The question says, in terms of the infection model you used, how did you select this model and were there any other models explored? There is another question says, how was your study integrated with the other international studies of the COMO consortium?
Thank you, Bashar, and thank you for this question. So in terms of the model that we used, I mean, I was originally a part of a COMO consortium, and then this is where, I mean, I was because I learned about the COMO model, so I was interested to use it. And then when I approached the start to establish the Northwest modeling team, and then I introduced to them and also we were also at the same time a discussion with the Northeast also of Syria, because our aim is not only to be only in the Northwest, we want to cover all Syria one day maybe with different modeling regions. And then when I introduced the model, and then I think we explored, because in the COMO consortium you can use any model you want. They are happy to provide with the technical support, and the team, I mean, we thought that it is the most suitable for our context, but we are open to develop it later on. It's continuous development of the modeling, and then maybe later on if we find other maybe parameters, we were thinking to add some parameters about density. So we're open to collaboration with other people who are interested. And in terms of the study, how your study integrated with the other international studies of the COMO. So as Naser said, the COMO consortium has, over 45 countries involved. And each week we are sharing updates about what we're doing in the model. And this, I think this collaboration with other teams from other countries, I think it's very important. And for instance, also sometimes we learn, we had someone from Bangladesh team, he joined the Northwest team meeting, and then this collaboration we think is very very important. But as a modeling team in each region, it's working individual, but we just keep communication and collaboration. Thank you.
Okay, thank you very much for your answer. We have another question to Dr. Abdulkarim. Why do you think that, it's from another anonymous attendee, why do you think that volunteers and disinfection campaigns delayed the outbreak in Northwest Syria? I believe that it was the restricted cross-border movement that was the most effective. What do you think, please?
Thank you for the question. And actually, in my presentation, I did not mean actually to, there is no indication that the volunteers and the disinfection campaigns are the reason behind delaying the outbreak. What I meant was the delaying the outbreak was, a result of a good planning process that was set on kind of a sub-national level. So the planning process was, I think, in the right direction, and the planning process included a lot of measures, including primarily the restrictions of cross-border movements and other social distancing measures. And I think if I was asked as an epidemiologist, what was kind of the main reason for delaying the outbreak in northwest of Syria, I would say is the natural isolation of this region. Because in this region, there is no movement compared to all other movements in Syria. And as we know, the virus would transmit from people. And as we know, the first case that appeared was identified in northwest of Syria came from a doctor who crossed the border from Gaziantep in Turkey to northwest of Syria. So I think the natural isolation could be number one. And I think what we need to focus on is the planning process, is having a governance system to do a subnational planning in such context is something unique, and that's what our paper highlights.
Okay, thank you very much. I think we have 4 minutes before our break and 2 questions. The first question is to Dr. Houssam. It says, some believe that the lack of engagement with local authorities was the largest barrier to implementing preventive measures. How do you see that?
Yep. So from what we got from the interviews is that people perceive the local health actors as a trusted entities to provide information and updates about the disease. But because of the health system fragmentation and because of the authority gap, there was no way that any like regulation to be imposed on the population, or like the lockdowns cannot be imposed on the communities. And that's again because of this fragmentation in the complicated political situation on the ground. So when talking about the engagement of the local with the local authorities, again we have part of it related to information and the trust regarding the health system as healthcare providers, and there is the political part of the health system which is still not mature enough to have an impact on the community.
Okay, thank you very much.